Welcome everybody. Very warm welcome actually to everyone joining our virtual event this evening. It's called Paths to Parenthood. I'm going to try and give an overview of IVF and all things associated with it. So it's a real whistle-stop tour. So I'm Alison Campbell. I'm the Chief Scientific Officer of CARE, and I'm going to be hosting this event. So just before we get started, it's always nice to know what to expect. So I will say this will last around 40 minutes, maybe a little bit longer. We've got 3 short information videos all about Care Fertility, about our team, and I'm going to walk you through a typical IVF pathway. So right from a consultation through to embryo transfer. We've got pictures, we've got videos, photos, so hopefully it will be really informative for you. We're going to intersperse this with a Q&A session. So I've got a special guest visitor, Dr. Mariano Mascarenhas, who will be joining me quite soon. So get your questions ready. You can ask your questions in the private questions tab, or you can ask them in the public chat. So if you use a public chat, then people will be able to see your name. So whichever is better for you, please do that. You can also send your questions to us by email. That's events@carefertility.com. So lots of ways to ask your burning questions. Now, if we don't get a chance to answer all of them this evening, then we will get back to you after the event. So we will address all of your questions. We've got our new patient inquiry team available, I believe. So they will be able to answer any calls if you want to give us a ring. The number this evening, 0800 564 2270. So we'll start with a short video just to welcome you and give you a little bit of an idea of what's to come.
Family. It's who we are and who we're always going to be. It's the important little moments, the big emotions, the beating heart at the centre of our world. It's the journey that we take there, together, one step at a time. Family is the one thing we'll always care about the most, because we believe that family is for everyone. And through our care, we'll do everything we can to make your dream real. We don't just care, we are care.
My name is Professor Charles Kingsland, and I'm the Group Clinical Director for Care Fertility. At CARE, our number one belief is family for everyone, and this means we do everything possible to help everyone start or grow their family. We know that nothing is as important as family, and that's why we care so much about wanting to give every patient that comes to us their best chance of having a baby. Of course, families come in all shapes and sizes. We get heterosexual couples, couples of the same sex, we get single patients wanting to start a family, we get NHS patients. When you have a fertility problem, there should be facilities available for you to get the best advice and the best treatment readily available to give you the best chance of having a baby at a time in your life that is best for you. We will use all our knowledge and experience combined with highly individualized treatment, personal treatment, to help you have the family you are longing for.
Unbeknown to Gemma and I, we both carry a gene, a deafness gene. We actually have a daughter who was 3, but who was born prematurely deaf. And we were given the option and chose to go down a fertility treatment to kind of avoid our second child having that same gene.
We were very lucky in the fact that the clinic was only down the road from us. So we felt there was one around the corner. It had good reviews. We just felt it was good for us, didn't we?
The whole package made us just feel really comfortable that actually going with CARE was the right decision.
So the team that we worked with at CARE were unbelievable. They were caring, they were sensitive, they were compassionate, empathetic. And even when I was ringing out with, I was feeling pains down one side, that the reassurance that they gave me, they honestly do hold your hand every single step of the way. And I feel like they lived the journey with us.
So I've had several treatments with Care. I now have a baby, and that's taken a number of treatments, fertility treatments, different alternatives, different medicines to try and get it to work for me. I have always said I would recommend Care Fertility. I would recommend them for the comfort factor that I received, the friendliness, and just I think the word is my faith in Care Fertility.
So around 1 in 6 people need help starting a family, and we do truly believe that family is for everyone, and so we help all different types of patients, as we just heard in that video. So we're going to focus mainly on a general IVF practice across over the next half an hour or so, but whether you have treatment with your own eggs and your own sperm or with help of a donor, the principles are all going to be the same, so hopefully it will be useful. So we have clinics across the UK, we have in Dublin and several satellite facilities all over the UK. And more recently, we have now a clinic in the US, in Charlotte, North Carolina, and we have 3 clinics in Spain. So we're all over the place, and we are readily accessible for patients all over. So we'll move on to the next slide. Am I driving this? Sorry. There we are. So this is Shah, and she's the head of patient experience, and she heads up a whole team who are dedicated to new patients, to supporting new patients and making sure that we make this journey as straightforward as possible. And members of her team are going to be available if you want to call in to talk to them and ask any questions. Very open to dealing with any questions that you may have. Right, so we start with the diagnosis. So getting the right diagnosis and gathering information from you is really important so that we know what we're offering you is the best advice. We need to give you pre-treatment tests, very helpful to help us understand which treatment will suit you best. So often these would be an AMH blood test. These terms may sound familiar to you, ultrasound scan and semen analysis. So from those pieces of information, it really helps us direct you in the right way for your treatment. And if you've had these tests done before you reach Care, before you have a consultation, we can upload the results, or you can, into your portal. We have a patient portal. So there's often no need to repeat these tests. And sometimes we will recommend that they need to be repeated, but often it's not necessary. And we don't want to do tests if they've already been done and they're recent enough and they're informing our advice to you. So the first stage, once we've got some test results, will be the consultation. This is George, he's in Care Sheffield. And in the initial consultation, your Care Fertility specialist will listen to your plans, listen to your wishes. They're going to go through any existing results that you might have had. They'll explain if you do need any further tests, because if they're going to be beneficial to help inform your treatment, if any treatment is necessary. And they'll discuss all of the treatment options and the chances of success with the different options with you. So our intention is that when you go away from the consultation, you have all of that detailed information about the treatment options for you, and you can consider that in your own time. So you'll go away knowing where exactly you can find any support from our team, and the treatments that have been recommended, and any costs that may have been associated with the treatments. So whether your diagnosis is simple or complicated, we have the depth of experience to give you the best chance of starting your family. So we've got a really big team, as you saw from the map. So if there's something really complex, particularly about your situation, almost certainly we've seen it before, and we've got the experts available and accessible to help work together and find the best offering for you. So we have a portal. This patient portal is it's been a revelation. It's after your consultation, so our clinic teams will be able to upload any information you need onto your portal. You can populate your portal with previous test results, as we've said, and you can access it on your tablets, on your mobile, on your desktop, laptop, any way you wish. So really trying to make things as straightforward as possible for you, so everything is in one place. So let's talk about the IVF process. So as I said before, really, whether you're using donated eggs and sperm, whether you're using your own eggs and sperm, your partner's sperm, fresh sperm or frozen, fresh eggs or frozen eggs, the process is largely the same. Of course, everybody's treatment needs are different. They're very different, but we pride ourselves in offering individualized treatment following this structured pathway. So our treatment offerings start quite simple with intrauterine insemination, for example. So we can monitor your treatments, your natural cycle, and we can inseminate just on a monthly basis if necessary. And we can go straight through to very technologically sophisticated treatments. So I'll talk about those a little bit later on. So I'm going to walk you through an IVF process, which most of our patients will undergo. So it starts with ovarian stimulation. So the very first stage is to stimulate the ovaries with medication to try and develop follicles on them from which we can collect eggs. So the fundamentals behind this is that if we can collect a good number of mature eggs, then we've got a higher chance of getting a good number of embryos. And if we've got some embryos, then that's fabulous. We can choose the best one. We're really specialized at selecting the best embryo. So it's all about getting a good number of eggs to start with. And the way we do this is to take over the menstrual cycle, to stimulate the ovaries, and we need to monitor to see how those follicles are developing. So everyone's issued with medication protocol, which one of our expert nurses will explain to you. And they'll also teach you how to administer a series of injections. So we can do that face-to-face, or we've also got informative videos, online teaching videos that can help you with that. So there's just a picture here of the needle. It's a very fine needle, and we'll really support you, making sure that you're very comfortable with giving these injections, very important injections, so that we can get those eggs that we need to make embryos from. And so during this stimulation phase, whilst those follicles are developing, we need to monitor how that's going. So this is Rima from Care Birmingham, and she's just here showing that we can monitor them using ultrasound scan. So a transvaginal scan, it's usually we do this a couple of times during the stimulation phase. And when we're happy that we can see a good number of follicles, then we'll ask you to have a final trigger injection. We call it a trigger injection, and that helps the maturation of the eggs. It's usually given in the evening, and then your egg collection will be scheduled, and very specifically around 36 hours after that trigger injection. So the next stage is the egg collection. So we've stimulated the ovaries, we've given the trigger injection, so inside the eggs have matured, hopefully, and we'll bring you in for the egg collection. It's a really straightforward procedure, very routine, and we use ultrasound again. We use a guided needle to get to the follicles, and we just carefully extract the eggs from these follicles. It takes about 20 minutes or so, and it's usually just followed by a short rest before you're ready to go home. If you're using donor eggs, then they would be thawed around the time that the sperm is being prepared. So we can use donor eggs or your own eggs, and they can be fresh or frozen. But whilst we're preparing those eggs, we're also preparing the equally important sperm. So the sperm sample is generally prepared the same morning. So it's ready for the insemination early afternoon. You might be able to play the video here. And currently, well, no, they're not. Oh, yeah, there we go. There's some sperm moving. And they may have been fresh, they may have been frozen, they can be surgically recovered, and partner sperm, donor sperm, but they all look very similar to this. Some people have many sperm, millions of them, and some people with just single figures. I've seen it in the past. So very variable in terms of sperm quality, but our embryologists are very specialised at counting them, preparing them, and communicating with you how they're looking. So we will make a point of making sure that the patients understand what we're faced with in terms of the eggs and the sperm on the day of the very important insemination, where we bring them together to create the embryos. So the IVF process. So this is where we mix the eggs and sperm to create embryos, hopefully to achieve fertilization. It's all important, fertilization. So IVF, with conventional IVF, which was used for Louise Brown, who you may have heard of, the first IVF baby, we mix the eggs and sperm. So we've carefully prepared them. We've diluted the sperm to a suitable concentration. We mix them with the eggs that we've just collected or we've just thawed, and we leave them overnight. And the alternative method to achieve fertilization is ICSI, and it's generally used when sperm numbers are low. And this is Lena here at the ICSI rig, and here's a nice video of the ICSI procedure. Not always used when the sperm numbers are low. It may be that we decide it's sensible to use it because there's been a previous IVF cycle with poor fertilization or failed fertilization. If you look here carefully, you'll see the sperm now just entering the egg. So it's a micro manipulation technique. So the egg there has been prepared. We've removed the nursing cells so that we can see exactly what we're doing. We hold the egg very still, and we use high magnification on this equipment here. And we put this fine needle with the sperm inside into the middle of the egg. So that needle that you saw there is 10 times finer than a human hair, really fine. So our embryologists have these joysticks, really, the very specialized piece of equipment, so they can manipulate and catch the sperm and pop it into the center of the egg. Highly successful procedure. So after the insemination, so after we've done the IVF or the ICSI, we will assess for fertilization. And we're looking for 2 nuclei, and that tells us, we use our microscopes, we look for 2 circles, 2 nuclei, and it tells us that normal fertilization has been achieved. We use time-lapse systems like this one here very often, and this also helps us watch the eggs and embryos fertilize and develop. So the fertilization check is the morning after the egg collection and insemination. We'll make a call to every patient to let them know what's happened, how many have fertilized. It's one of the very special moments in the role of the embryologist. And then we will continue to culture or grow the embryos for a few more days following the fertilization confirmation to see how they develop in preparation for embryo transfer. So this here is the time-lapse device. So this piece of equipment is photographing those fertilized eggs through multiple focal planes about every 10 minutes. So we don't need to disturb them to see how they're developing. So we're very experienced at this. And here we have just 2 of the ways that we use to select embryos. So we've grown these embryos, they've fertilized, let's hope, and we grow them for a few days. And we've got 2 very high technological procedures that we are very familiar with to help us choose the best embryo. So the first one here is CareMaps. So it stands for morphokinetic algorithms to predict success. So morphokinetics, it's the way the embryos are developing, the shapes they're making, the way the cells are dividing, and very importantly, the timing points that they're doing this. And we've created algorithms so we can identify which embryo is the most likely to achieve a baby. So we've published this work. We are world experts in this area. And we've recently introduced artificial intelligence to improve the accuracy of this technique. We've recently won a couple of awards as well, so I'm very proud to share that with you. Now, the other method that we use for embryo selection is called PGTA. So it's pre-implantation genetic testing for aneuploidy. It's a lot of words, but basically same stage embryo here. It's a blastocyst stage embryo, and we'll remove just a few cells, usually 3 to 5 cells, again with the same equipment that we saw before for ICSIs and micromanipulation. Take a few cells, they'll go off to the genetics laboratory for testing, and what we're looking for is a count of chromosomes, because really when women are aging, particularly over 37, their egg quality declines, so the number of chromosomes in the eggs can often be incorrect. It's called aneuploidy, and it's a terrible thing really, because it can result in failure of embryos to implant, it can result in miscarriage, or it could result in a child affected by an aneuploid condition. So our embryologists will take a few cells for those patients that this treatment's indicated for, and we'll get the result back. So it'll help us understand which embryos have the right copy number of chromosomes. So we can see we've got lots of tools in our toolkit to help maximize the chance of success for our patients. So embryo transfer is the next stage, and we use one of those techniques or conventional assessment down the microscope to choose the best embryo for transfer. And so irrespective of how we've chosen the embryo, we transfer them in exactly the same way. So the embryologist will load the embryo into a soft catheter. It's inserted through the vagina and the cervix using ultrasound guidance. It just takes about 10-15 minutes. We show the embryo on a screen often. So then after that, we've put the embryo back and you can go back to normal activities. Some patients choose to rest, but as long as you're not exerting yourself too much after embryo transfer, that's fine. And then there's a 2-week wait. They call it the 2-week wait, which is as the embryo transfer, before you wait for your pregnancy test. And we'll generally provide a progesterone medication during this phase between the embryo transfer and the pregnancy test to support implantation. And so that's about 14 to 16 days later, after the transfer, we'll do the pregnancy test. If it's positive, then you come back to the clinic for a scan a few weeks later. If it's negative, then we will offer our support, and we have counselling services available, and we'll also arrange a follow-up consultation so that we can go through the treatment and talk about what you want to do next, whether you want to try again, have a rest, or what we can learn from the treatment that's just been undertaken. We'll just move on to just a few minutes talking about donation. So we've got a really large and experienced team of donation staff and counselling specialists at CARE. So we've got everything in place should you need to use donor eggs, sperm or embryos. And we're one of very few clinics around the world, I would say, that have our own donor sperm and donor egg banks. We've got a lot of experience, but we want to make sure that patients have a big choice. And so we do also partner with other cryobanks so that we can offer a broad choice of donors to our patients. And surrogacy as well, we're very specialised at that. We've recently won Surrogacy Clinic of the Year. And surrogacy, as we know, it can be quite complex, but I'd say our team make relatively light work of it. They have a really clear pathway. They know exactly what they're doing, and they're really supportive to help patients if they need this path to parenthood. And support is very, very important. So I'll just say a few words about support. We hold regular online support groups. We have forum. We have, I'll show you the next slide, just it's best to see this. So we have the team, the new patient team that can support patients. We have a team of pals that can support them through their treatment. We've got a forum so patients can liaise with each other, a buddy scheme, our counsellors, we've said. We have social media channels to communicate also with patients. And importantly, I think this resource hub. So if you've been for an injection teach, for example, and you want a refresher, everything's there, so we can help you just reiterate the messages. We don't want anyone to feel intimidated or daunted or nervous about the treatment that they're undergoing. So lots of support. We take this very, very seriously. And we're here to support you, not just medically and emotionally, but financially as well. We have Care Pay. So this is exclusive, the individually tailored funding packages. So these are designed by us to give our patients financial peace of mind, and as well as the peace of mind that they're getting the best medicine and the best treatment and support. So we created these products following patient feedback. It's managed entirely by our in-house team. So patients have a more seamless experience. There are alternative ways to fund IVF, but the feedback is that this is a really supportive and straightforward way to do it. So we're going to move on now to our first question and answer session. I think we'll probably condense it and we'll have one 15-20 minute Q&A session. So please send your questions in. I'm going to be with Mariano, Dr. Mariano from Leeds. So let's welcome him onto the stage. Let's call it a stage on Livestorm, and we'll start going through some of the questions that have already been sent in and some that you've been sending as you go, as we've been talking. Oh, hello. Hi, Mariano.
Hi, Alison.
Nice to see you.
Nice to see you too.
Are you well? Great. So I'm going to see if I can go on a full screen, make us bigger. Let's see. How's that? Or made you big. That's good. Right. So we've got lots of questions coming in. Now let's have a look what we've got. I'll go and have a. Can you see them as well?
Yeah, I've replied to a few.
Right. I'll fire a few questions at you because you're our medical expert. Let's see. Choose a good one. There's so many. Right. Do you know if ICSI is included in the multi-cycle program?
Yes.
Yes?
Yes. Yeah.
Great. Oh, there's a lot of questions about the Care Pay IVF refund program. So you just want to talk to us a little bit about the about Care Pay and the different types of funding that we have available.
Certainly. So CAPE, we have the refund options and the multi-cycle options. The multi-cycle option is essentially if one cycle of egg retrieval and the subsequent embryo transfers are unsuccessful, then the second cycle of egg retrieval is also included. So, and the good thing about CAPE is it includes any number of frozen embryo transfers till you have a baby. So that's one key difference. So it gives you that peace of mind and also gives you that flexibility in deciding how many embryos to transfer, for example, in order to optimize your safety. So from those points of view, CAPE is a good option.
Oh, got a visitor. Hello. Oh, that's okay. Sorry. Usually I have cats arriving, but we're okay tonight.
Sorry about that.
No problem.
So the refund is essentially a program where if you do not have a child by the end of the specified number of cycles, let's say 2 cycles of egg retrieval and so forth, you get a certain proportion of the money you've paid back. Now, I am not a financial expert, so I don't know about the nitty-gritties of it. But overall, they seem to be quite good options. The one caveat is the medications are not included in the treatment cost. So it's worthwhile just having a chat with your particular medical team about how much the medication cost might be.
Sounds good. And we've got a brochure which covers all of this. So anybody who would like to see that just needs to get in touch and we'll happily send a link to the brochure. Now we've got a question from someone who is 19 and has had both tubes removed due to infection and endometriosis. And they're asking whether we know if they would be funded for IVF treatment by the NHS.
Yes, it very much depends on the funding criteria. Each geographical area has a funding criteria. Nowadays, they go by what's called Integrated Care Boards or ICB. For example, I work in Leeds, and we come under the Yorkshire and Humber Integrated Care Board. And for example, as per our criteria, if neither partner has a child from present or previous relationships, that holds good for both heterosexual and same-sex relationships, you're funded for 1 cycle of IVF. So that's the current criteria. But of course, this criteria will vary from location to location. And we are, I mean, as fertility specialists, we have been asking for a while for the criteria to be made uniform all over the UK. But unfortunately, that is something which is not completely within our control. But I can say what holds good for the Yorkshire criteria.
Yeah, great. It is. It's not ideal that it's a postcode lottery. So patients probably best to talk to their GP or find out locally what's available for them.
Yeah.
But most of our clinics, we can treat NHS patients. We do treat both private pay and NHS patients. So what is embryo glue? Do you want me to do that one, or would you like
Yes.
to do that?
No, it's under your domain, so I would defer to your expertise.
Yeah. So, well, embryo glue, it's a particular medium, so a solution that we can use to transfer the embryo. So it's a little bit more viscous. It's a bit thicker than the culture medium that's used as standard. It's enriched with hyaluronan. So it's a very clever name, and it's not really a glue. It's not necessarily magic. It doesn't glue the embryo into the womb, but there's some evidence that it can be effective at enhancing pregnancy rates for some patients. So, like we mentioned before, the Care Fertility Toolbox is vast. We have access to all sorts of treatments. So whenever patients come to us, we would decide what's best for them and would recommend particular treatments and solutions. That's not the only specialized solution that we have in our embryology fridges. We have all sorts, and that's, I think, really important that we have all of these things available. If we believe they're indicated for our patients, then we will offer them up. We've got a question here. Do you need your period to have returned to do a transfer after you've had a baby?
So I would class this question into 3 different sections. Number 1, when can you have a baby after you've had a child? When can you start trying for another child? And number 2 is, if your periods haven't returned because you're breastfeeding, or your periods haven't returned because your periods were irregular before, for example, if you had polycystic ovary syndrome or some other condition which makes your periods irregular. So if the question is about when is the earliest you can plan fertility treatment after having had a child, it depends on a couple of factors. For example, did you have any problems during your pregnancy? Was vaginal birth, cesarean section? Was there any complications after childbirth? And also, what's your age? What sort of flexibility in certain time scales, ovarian reserve? All these factors come into play. General rule of thumb, we advise generally to wait at least 6 months. The UK guidelines, in fact, the UK government guidelines recommend waiting around 12 months, ideally, because that gives enough time for the mom to recover and replenish her stores, because pregnancy is a stressful process, puts lots of strain on the mom's body. But again, it depends. If someone is healthy, eating well, they're taking all their healthy balanced diet and your 5 a day and everything, their body is going to bounce back quicker than someone maybe whose health is not as ideal. So it varies. But if the question is, if someone's breastfeeding, then it depends. Again, we need to have a conversation about the medications and so forth. But if it's a question of, okay, it's not any of the other things, it's just someone has irregular cycles, then certainly that's something we can intervene in order to perform the transfer. Yes.
Yeah, that's good. Good answer. That's the thing. It's never one or the other. It always depends on many factors. So that's the importance of personalized medicine, I guess. You need to sit down with the patient and decide what do they want and what's sensible and what's practical, and then work out the time frame together. So our next question is, could we talk a bit more about egg collection? So do we do egg collections under sedation, and how does that work?
So we use intravenous sedation, and essentially there are some drugs given into your bloodstream. It is not as deep as general anesthesia. And the key difference here is In general anesthesia, we have to have a machine do the breathing work for you, like a ventilator. Whereas in conscious sedation, essentially you are doing your own breathing. It's just that we are giving you these medications to help you from a pain relief perspective and sedation, reducing anxiety, and so forth. And we have experienced practitioners who will be giving the sedation, and the levels are titrated to how you're feeling, how your health is. And I even saw a note about a question about BMI coming up. And that's one of the reasons why we have a BMI threshold, because the safety of sedation is better when your BMI is below the threshold as against when it's higher.
Yes, makes sense. And the other benefit, I guess, that after the procedure, the recovery is much faster than a general anaesthetic, so they can go home and get on with wait for the important phone call about the fertilization the next day.
Yeah.
And we didn't mention too much about intrauterine insemination. I mentioned it very briefly in the presentation, but could you just explain the pros and cons of IUI? And then we'll just talk about what would a patient expect if they were to have an IUI, an intrauterine insemination.
As in IUI versus IVF?
Yes.
So now the question of IUI and IVF primarily comes when someone is having fertility treatment with donor sperm. And interestingly, it is a research project which I supervised in Dundee. We collected the data because we wanted to see at what point do we advise IVF in someone's fertility treatment journey. Now, of course, this depends on everything else being fine. If someone's fallopian tubes, for instance, are not patent, then IUI is not going to be useful. IVF is what would be useful. The question, we have to balance three different things here. Number one, now the relative invasiveness. IUI is much less invasive than IVF. The second thing we need to balance is how many cycles, the impact of time on eventual success rates. And number three, most importantly, what are your preferences? What do you wish to do? And in addition to these three things, sometimes the conversation comes about what funding is available. For instance, at least I can speak for the Yorkshire criteria, but if someone's fallopian tubes are patent, they're technically eligible for 6 cycles of IUI and 1 cycle of IVF. But if they go straight to IVF, then they lose out on the 6 cycles of funding of IUI they would have obtained. So it's a delicate balance, really. What seems to be the case on a generally, if you're under 38, it's probably you can go for 6 cycles of IUI. If you're over 38, then we need to have a conversation about how many cycles of IUI versus IVF.
Yeah, that makes sense. Let's talk a little bit about add-ons. So add-ons being like a supplementary treatment. So we can do a routine IVF, but we've also got all these tools in our toolbox that could be called add-ons, and they are often called add-ons. So for a person who's 29 with low ovarian reserve, what would we have in our toolbox? It may not be an add-on necessarily, but what would you recommend to maximize the chance of success? So they've got a low ovarian reserve. The expectation is we're not going to collect a very high number of eggs. So what would we do? What magic would we work for them?
Now, it's important. This is presuming that someone is still having cycles and they're still ovulating and so forth. So with that caveat, we need to sort of class these sort of interventions into things which definitely are useful and things which we do not know, but we need to weigh up the possible benefits versus risks. And when we look at things which are definitely useful in these circumstances, it's probably wise to go for IVF if that person is at a stage where they would be ready to plan for a family. Then IVF is something worthwhile considering because that often provides the fastest route to a pregnancy. Now, it's important to put a caveat here. A low egg reserve doesn't automatically mean the egg quality is poor. In fact, myself and Dr. Alison Richardson published a paper looking at IVF outcomes in women with low versus normal egg reserve. And what we found was once someone is pregnant, there's no difference in the risk of miscarriage, preterm birth defects, or anything of that sort. It purely is, number of eggs you get, which in turn influences the chances of having an embryo to transfer. In terms of, there are lots of supplements being advertised. And some of them have a bit more evidence base behind them than others. For example, coenzyme Q10 seems to be having a few more trials, but we still don't have the large scale trials looking at live birth rate, which is what really matters. The trials which we have are rather small and look at surrogate markers like embryos and eggs, rather than the question what everyone wants to know is, my chance of having a baby going to be higher? So it's a bit so short answer to a complex question is
Yeah.
IVF. Add-ons, we are not terribly sure at the moment, but you can have a conversation with your clinician. Coenzyme Q10, the advantage is there are no downsides. It's just a supplement. There are no side effects.
Exactly. Yeah. And I think talking generally about add-ons, one of the benefits of us being such a big group of clinics working in a very similar way, we've got a lot of, not just expertise, we've got a lot of data. So we can use that data and we mine it all the time. So these add-ons that may not be necessarily truly evidence-based and published, where patients have had them, they've always had a choice. If they've had an add-on, we've got big data of our own to say, well, has this worked in our hands? So we can share that information with patients. And I think that helps them feel a bit more confident about their decision making. And of course, it is their decision in the end.
Yeah.
Just a couple more questions. I just want to say a few words generally about success rates. We've not really had too many questions about success rates, but they do come up, and it's always difficult to speak broadly about them because every patient's different. But I think the best thing to do is contact the clinic. If you want to know what your success rates would be, what your chance of success would be based on your own personal situation, then we're able to give you that, not historical data. And the website does show the published HFEA, the validated data, but it's always a couple of years out of date and it's broken down by ages, and there are lots of different ways to cut it. So we're often able to be more precise than that with individual patients. So I would encourage people to call and we'll support them with that. Right, a quick one about if a patient's on the pill. Oh, sorry, go on.
About the success rates, the CareMaps AI algorithm does help us fine-tune the predicted chances of implantation to a greater degree than we can based on the raw age-based data. Now, it's important to note, it's a selection algorithm. It's not making embryos better, but it helps us track them better and helps us fine-tune and provide you more tailored information as to the prospects with those particular embryos.
Yeah, it's a phenomenal tool. I think we must never take it for granted. It's built on huge data. It's world class. We're going to New Orleans to a conference in a month's time talking about it. We're sharing this knowledge around the world because it is a phenomenal tool, and it just gives us so much precision in terms of embryo selection, non-invasive, accurate information. And I know you've done some great work looking at the data based on patient ages, which is so informative for patients, and I think that's really helpful. And we're predicting live birth, we're predicting babies. It's not just what's my chance of pregnancy, this is what's my chance of having my baby. So it's an amazing thing. And now if a patient came to have treatment and they have been on the pill or other hormonal therapies, is that okay, or do we need to wait until that's all out of the system before we can get started?
Generally, your ovaries recover much quicker than you anticipate. So the short answer to a complicated question is, again, it depends. Each person's body takes a bit longer to recover from any medications and so forth, and the pill is no exception. Generally, I would, if you notice when your periods are starting to become regular after you stop the pill or take the implant out, then it doesn't seem after that it should be fine. You should be absolutely fine. Interestingly, we performed a analysis of whether people can freeze eggs without taking out the hormonal implant. It was very early data, but in the selected circumstances where people didn't want to switch to a different form of contraception, we actually could leave the implant in and still freeze their eggs. This is for patients who are imminently due to have cancer therapy. where they didn't want to come off contraception and risk an unintended pregnancy. And what we found was, surprisingly, we were able to get a similar number of eggs, and importantly, similar levels of egg maturity with egg freezing in women on the implant. So it's not necessarily the case that you can't do treatment, it just needs to be individualized.
Yeah, perfect, makes sense. Last question. If the uterine lining is found to be really thin, so we may not want to transfer an embryo into a very thin endometrial lining, the lining of the womb, for those people who may not understand that term. So what would we do? What can we do to thicken the lining of the womb, the lining of the endometrium?
So what we do is look at whether there are any reasons for that. So it depends. Again, it depends, but depending on the clinical circumstances, we may need to do further assessments. It might include further imaging. We have 3D ultrasound facilities. We may use some other method of looking inside the uterus, like a hysteroscopy, to look at the lining directly. These are all options. In a frozen embryo transfer, we have quite a few tools at our disposal, like estrogen tablets. We can vary the dose, use patches, and so forth. So those are things we can use. And it's important to note that what's defined as a thin endometrium may not necessarily mean that is an endometrial thickness where pregnancies are impossible, because pregnancies have been reported even with endometria, which mean a lining of the womb, even if they are on the thinner side. There's a good amount of data, particularly a large data set from Canada, where they included more than 60,000 embryo transfers. And one last factor to take into account is, yes, the pregnancy rates will be affected, but you sometimes, if you think from a first principle perspective, some people do have, unfortunately, ectopic pregnancies in the fallopian tube where there is no endometrium. So it's not always the case embryos can never implant. It's just the numbers are low, and we need to have a conversation about what those acceptable numbers might be for each person.
Yeah, great. That's really been so informative. Thank you very much, Mariano. So we've come to the end of our event already. That went quickly, but we have got a couple of videos just to show you, just to show everyone watching, just to tie it all up, hopefully, and say a little bit more about care, fertility. So we've got 2 short videos. We'll do them back to back, and then we'll say goodbye. But I hope it's been informative for everybody, and thank you again. It's been a pleasure talking to you, Mariano.
Thank you, Alison. It's been a pleasure talking. Take care.
I'm Shah, and I manage Care's new patient inquiry team. We're here to make it easy for you to take your very first step in your fertility journey. We completely understand how nervous and excited you might be when you contact us. This is the start of a life-changing process and hopefully the beginning of an amazing future as a family. So it's really important that we give you all the information you need. That way, we can help you to feel much more comfortable and confident with your treatment. Whatever you need to talk about, I want to reassure you that no question is silly or trivial. We appreciate that there might be a lot to take in at first, but don't worry, we'll send you a clear information pack about the treatments you're interested in, and we're always here for any follow-up queries. My team also manage inquiries about Care Pay, our range of funding packages which are exclusive to Care Fertility patients. When you're ready, we can book you a virtual consultation with a specialist fertility doctor from your local care clinic. So if you want more information, have a question, or wish to book an appointment, call my team. We want you to know that we are here for you at every stage of your fertility journey. We say that our patients become part of our care family, and it's true. We care deeply about you and your future, and our teams are here to make sure you have all the support you need.
The reason why we chose Care was just, one, the care that they give you. the aftercare that they have available to you, and the fact that they offer different forms of treatment, and they listen to you. One thing that I've identified and what I've noticed when speaking to other people that I've met within the infertility community is there's a lot of clinics out there that don't necessarily listen to you as the patient. It was kind of, well, one size fits all, but with care that didn't seem to be the case at all. They took everything into consideration, they listened to your concerns, they listened to you as a person, and they put a package and a process in place that will help you, and, you know, fingers crossed, will give you that positive result at the end of it. So without a shadow of a doubt, if I had to go through it again, I would definitely go back to care.
Oh, the support at care was brilliant, yeah. I mean, the nurses were brilliant for us. You feel so
looked after,
cared by the whole team. We felt that they did care, and it wasn't just for them getting something out of it. It was actually that
ongoing support.
Yeah, and they wanted it to work for us.
Care Fertility started over 20 years ago with one clinic and the goal of helping patients achieve their dream of family through truly personal care and the most scientifically advanced fertility treatments. We've grown from that one clinic. We now have clinics across the UK, and many people have become part of our care family with over 50,000 care babies in the world. But one thing has and always will remain the same. We care for each and every patient. We care about your dreams of having a baby, and we put our heart and soul into every aspect of what care can offer you. To provide you with the best care possible and to give you your best chance of success and treatment, we look to our own care family. From our consultants, embryologists, and nurses to our admin teams and specialist fertility counsellors, we've also put a lot of thought into how we improve each and every step of your journey, which will no doubt begin with lots of questions. We know that thinking about starting IVF can be daunting for some, and that's why our care, patient services and support teams will always be there for you whenever you have a question, need advice, or simply want someone to talk to, so that you feel completely confident and in control of your fertility options. So yes, we have grown and developed over the years, but care and empathy are always at the heart of who we are. We are passionate about changing lives and creating futures, and I hope that this shines through in everything we do and everyone you meet at all of our clinics. We don't just care, we are care.
One in 6 people need help to grow their family. You're not alone. And our care family will do everything we can to help your dream of family come true. There are over 50,000 care babies in the world today. And behind this success is our promise to make more heartfelt dreams of family become reality by ensuring our care goes into everything we do for all our patients every single day. You will receive truly individualised treatment, a patient-centric approach with empathy at its heart. We understand how nervous and excited you might be about getting started, but you can be assured of kindness, empathy, and all the information you need from our new patient inquiry team. We are all here to make it easy for you to take your very first step in your fertility journey. Call our team on 0800 564 2270 to learn more and book an appointment. We don't just care, we are care.
Right, just to say thank you once again. I hope you've enjoyed it. I hope you found it informative. Please send us any feedback you may have. We want to keep making it better and better and more informative for our patients and future patients. So thanks very much again, and good evening.
Thank you.